Thank you very much again for your time. And at the moment, I want to deal with the part of our general information pack that we would like to share with you as part of the Emergency Preparedness Committee for Charlotte Maxeke Johannesburg Hospital here in Gauteng Province. As a member of our healthcare systems, or you might find yourself in another hospital, I hope you find this very, very informative, and it will help you to set the ways and expectations moving forward. This is the general info around what we're seeing in our institution. By now, you should be having a layout of our hospital. And by now, you should be aware of the different blocks. Block 1, where we have predominantly obs and gynae and a little bit of pediatrics, neonates. Block 2, where we have a lot more of pediatric services and subspecialties, including the radiology. Block 3, where the surgical specialties are there. Block 4, which is a green block, where we end up finding some of the medical wards and some of the follow-up things. And Block 5, which should be known to you by now, as where most of some of the ICUs and the emergency departments are there. The emergency medicine specialties are there. Emergency department is on 6. Administration of the hospital is Block 7. And as you know, this is an institution that is attached to the university, and that is the building that represents our health sciences building in relationship to the University of the Witwatersrand. As you come in, most of the emergencies and almost all of the emergencies will come through here next to our helipad. And I hope that this orientation gives you a general understanding of how the hospital is situated. And this will be obviously the differences in terms of the south and the north. Parking for most of us will go past the nursing complexes and come at the back. And for currently, you will also have entrance for parking coming from the other side of the university and park from behind. So know your hospital, because it's important that whenever an emergency does occur, at least you are able to maneuver around and know what needs to be done. So let's go to the mass casualty guidelines and what we do in this hospital. So you might find that there are 3, or you will find that there are 3 key codes that we use: the code green, the code yellow, and the code red. What does it mean to you? When we're talking about code green, that's when it's something that is an event of importance or political event, but it doesn't require a lot of more action, doesn't require too much mobilization, and we are usually capable of dealing with it within the department that is involved under those circumstances. However, when it comes to mass casualties, and we're talking about code yellow, you would realize that it is not business as usual. And we've defined it from our point of view that there are at least more than 5 priority 1 patients arriving at once. So very complex patients that are arriving at once, therefore they would stretch the system, or there are more than 15 of multiple injured patients they might be walking, arriving at the same time. So this is what we call code yellow. What does it mean? It means we need to reorganize. We might need help from other departments. If it's trauma, we might need help from general surgery. We might need help from emergency department, but we don't necessarily have to mobilize the whole hospital to deal with this event. When we say code red, then we are saying it's a full mass casualty event. It's what we used to call disaster is declared, it's there. We are expecting multiple cases. We are expecting multiple burns patients. And in this case, at least P1s and P2s that are more than 10 coming at the same time, or at least a total of more than 30 of P3 patients. So you can imagine when we were dealing with the event relating to a stadium stampede a couple of years ago, where there were multitude of cases, it was a code red. You can imagine when we're dealing with the massive burns after a gas explosion not far from the hospital. It was code red. But there have been other incidences where we have not involved other people, which was a code yellow, because the activation was within the departments that were involved, and we were able to deal with it without a lot of problems. So you might ask yourself, now when they have declared, and let's give a typical code red, what does it mean? So part of the work that's going to happen is that we need to start, number one, diverting helicopters, because we use that helipad as an area for screening and for triaging our patients further, what we call the triage sieve. So we want to make sure that the usual cars that park in front of our emergency departments, the ambulances, all of those cars, first thing, we must evacuate them, because we want to have a good access for cars that come in to bring multiple patients and be able to deal with them without obstruction of a car that is anywhere within the emergency department. And we will divert the helis to another hospital, and those patients will come in terms of other routes to the hospital. So what would we do? As they come there in front, we then, depending on the numbers, we will divide them into different sections of the hospital. So it's no brainer that the more complex trauma, when they arrive, we will be putting them and circulating them within the trauma sphere, the 163, the emergency portion of the trauma department. Why? We have capabilities to deal with these patients. We can actually take our ventilation status to about 16 ventilated patients if we need to under emergency circumstances, whereas under normal circumstances, by the time we get to 5 or 6, we are overwhelmed. It is where the people that are working with complex trauma are concentrating, and therefore the system to deal with them and to manage them will be expedited and done in a much swifter way. What if we have more P1 patients? Then we have a good collaboration, and most of our emergency work, it's always done with a lot of trauma as well, and we're talking casualties and emergency department. And therefore, when we overflow, the other area where we will send this patient will be our emergency department, so that we are able in that medical emergency or surgical emergency department away from trauma, we can still be able to ventilate and optimize patients. So you can understand that to do this, once we know that a code red is declared, we have to activate and empty these areas, so that as multitudes of patients arrive, we are able to deal with them and work with them and increase the numbers and the capabilities to deal with these patients. Those are the unstable, the badly injured, the complex trauma patients. But in between, there's also a group of patients that are their blood pressure is not a big problem, their airway is not a problem, but they can't walk on their own. Then what we do, we empty the area that is very close to our emergency 165. We empty the area next door, which is the 167 region. And this is where we will sit in, and we will continue to see patients in different areas, allocate enough staff. And by the way, this system has managed to help us in the past, where we had received like 91 patients, and within 1 hour, 20 minutes, all patients were seen, all patients were triaged, and those that were discharged were already dispensed with money. Something that does not always occur on the day-to-day overwhelmed emergency departments that we live in this part of the world. But it is by cooperation and knowing which regions that these things will happen. In case you didn't know, there is a gynae OPD site, area 159. And this is the region that has been earmarked for us to be able to put P3s if we have multiple P3s. And we can actually accommodate between 300 and 350 P3s. And again, when we have those massive cases, we will then be able to send all the other support, maybe people that are not always in trauma, but they can deal with an ankle, they can deal with a perforated eardrum, they can deal with simple injuries. And therefore, we will put those patients that are walking wounded patients, that's where they will go in terms of the hospital. And so far, even though we have those capabilities, we've hardly ever needed to use this area in the past few years. We've been able to make space within what is available in creating space in the wards, in creating spaces in ICU, in using our emergency departments as a whole complex. We have been able to deal and manage with most of our recent emergency mass casualty events that we are dealing with. There is a designated ward, which is area 367, and this ward was just designated to deal with mass casualty events as part of our responsibility. We are not just responsible for the mass casualties as in injuries, explosions, etc. We also have to look after as well the hemorrhagic and the Congo fevers, etc. We also have to deal with mass events relating to emergency, medical emergencies as a group. So you can imagine that there is an area that has been designated so that when we are overwhelmed, we are able to admit those patients with strict rules. They have to be out within 48 hours. We must have found another plaque and another place for them, and we don't keep them here forever. When we ran into the problem with our fire incident that is known to most, obviously we ended up having to work around using this space for other areas. But as time moved on, we've been able to move on and reclaim it. It has beds, it's got capabilities to ventilate. It will help us to increase the capacity beyond what we do when we are preparing the wards, the other ICUs and the theaters in cases of emergency. There is also a stock that's dedicated for mass casualties. Again, during the renovation, it became a little bit of a challenge to manage it, but we have to maintain those stocks, make sure that they are there. And once in a while, we were exposed where some of the stocks were not the usual that you keep, for example, in bends and the amount of dressings that you use for bends. And we had to be able to deal with that and compensate for that. But overall, the filing system for emergency department is independent from what we use for the hospital care, and there are extra available consumables that are meant specifically to deal with mass casualties. It requires stock management. I'm sure most of you will find that interesting. So you can't manage these events with some guidelines and some terms of references. And for us, the emergency preparedness or the disaster management committee will have all of those clear with terms of references. What are the objectives? Who comes to the meetings, etc., like any other organization. It is also responsible to work up what we call the job cards, the guidelines to each sections, so that I know what the telephone exchange is expected to do. I know what the disaster committee leadership is supposed to do, what radiation and exposure, what trauma, what emergency medicine, what surgery, what call, and all of the departments are covered, and we have to always update all of these job cards. Remember, in an emergency, you need to find something that says, this is what I need to do now. I need to go open this. I need to go I need to phone somebody. It's not easy just to do and manage an emergency situation from your head. You have to make sure that there is clear written guidelines that can say and remind people of things that they are expected to do during mass casualties. So just to give you an example, there will be a clear that tells you who declares. So this will be for job card number 2 that is meant for the leadership, and it will tell you that it's either the chairman or the deputy or the coordinator, depending on who's available under those circumstances in that order, that can declare the emergency. And when they declare that green code or a yellow code, what are they supposed to do and what are they done and what are their action? And then they know and they are reminded, oh, this is a code green. I don't need to activate anything else major. This is a code yellow. Let me organize some more emergency department staff to come in. This is a code red. Let me make sure that the whole hospital is aware and is being mobilized to make sure that they react. So those job cards are specific. They will go to different areas. Here is an example of a telephone department or switchboard job card, which they know that once we said we have declared the code red, They must involve and inform the hospital CEO. They must make sure that the trauma call or consultant on call is aware, the emergency physician is aware, the senior security officer are aware. And all of those people, when they are aware, they go to their own individual job cards. And the individual job card will tell them how to activate, how to mobilize, and how to move forward. The clinical executive on call, for example, has theirs, and they know that now we must implement, for example, code red, we must implement the disaster immediately. And then therefore, what is it that I need to know? I must make sure the CEO has known. I must also make sure that the matrons and the other leaders in the nursing group have been organized. And the CEO of the hospital also has a job card. So if somebody is representing her during her leave, and has been assigned and has been delegated the duties of a CEO, that person needs to look at it and realize, oh, as a chief executive officer, then I need to know and to be informed of where we're going. I need to be able to immediately nominate somebody to come and run what we call the headquarters, where we will then set up so that we can manage and deal with the disaster and then again activate all the other issues. And clinical directors have their own, they know where they need to go. A clinical director must report to triage area in where most of the work is happening, which is 163. Then they need to be able to allocate and have some of the people that are involved, and they are the in-betweener in terms of what needs to be done. And that goes to other directors in the hospital. The director of logistics needs to know what they need to do. The director of supply chain, the director of nursing, the director, and most of these directors, when we do mobilize them, they'll be part of what we use in the headquarters, so that when we are running short of linen, when we are running short of food, when we are running short of some of the consumables, they are able to help and assist so that we can deal with the event in front of us. And it goes on to also the matrons that are on call, and they know who to call, how to activate the different members of the different blocks, and who is assigned to those areas. It's a very clearly well written in such a way that everybody, if they know their job card, we can all work together to achieve a harmonious way. It even goes to who must open up those headquarters, and when they are there in the headquarters, and this is about the information and IT department, and when they are there, what is it that their role is? The public relations officer. You remember in these events, the information and it's coordinated through the headquarters. It's not for you and I who are at the operational level to be involved in discussion. All the updates, all the information, we maintain our confidentiality, and the patient's confidentiality is maintained because we are healthcare workers. That is what we have sworn to do. But the rest of the information, how many patients came in, how many, that information will be managed through the CEO and the public relations officer. And it goes to even how do we deal with the mortuaries? How do we deal with the ICU? How do we deal with the other departments? How do we make sure that there is some food and refreshments available for the staff after they are working for most of the nights? And it goes on, and I hope it is helpful, including the stores moving forward. So you have to figure out, or you have to find, and your job card in your region, in your portfolio that you are involved with, so that you know what steps are expected to make sure that this mass casualty response is done in a way that will give us a good outcome. And I wanted to come a little bit to the issues around security. There is specific roles for security, including clearing the cars and making sure the cars are cleared, making sure that people that come in and their names are appropriate for the institution. And again, we've gone through different security companies, and we always have to continue teaching them and training them. But there is a specific role, and one of them is to cordon areas and to be able to direct people so that people know that they are not allowed to go into an unsafe area. So when we come during these mass events and mass casualties, most of us will go through and we will be at part of the assembly points. The matrons have got the different areas that they are coming to be able to coordinate work. and we will call people from all of those points so that they can come and assist. And part of those work, because you need to empty beds, you need to move patients to other hospitals, the transport is also expected. And that's why the director of logistics has to come so that he can make sure that we've got good transport. We can get patients out of the hospital, clear beds, make more beds so that we can deal with the new influx. Patients that are in for elective, how do we get them home if it is in the evening so that we are able to have an empty bed and they can come back for an elective operation at another period. We cannot meet as other days, and you'll see that the admission team as well as the casualty officers have to be able to open files, and the files are already labeled red, yellow, green, and this is the blue for those that do not have a good prognosis. And we just go, it's not about the details at this stage. It's just to go priority one, patient number one, priority one, number two. Now, later we can get the exact names, where they come from, and everything. Ultrasound on number one, on red patient number one, clothes for red patient number one. And later we come back and we identify once we have dealt with the threats to life at the initial phase of the management. And you need everybody. You need the porters participating, because moving of this patient, knowing where they need to go, availability of the porters is going to be critical. And that's why for us, from the emergency preparedness perspective, everybody matters during an emergency department. Just know what your role is and fulfill it to the best of your ability. And all of these things will come together in such a way that we get a good outcome. So we continue to have hospital meetings of this emergency preparedness or disaster committee. We continue to liaise as well and do some of the work with some of the executive members of that group. We're having plans to continue with the education, and this is one of them, to make it available as a virtual training. And we want a goal-oriented approach. Yes, the disaster ward at the moment, as I've said, we've been working in making sure it's available. We've been making sure that the storage room as well continues to be available for the mass casualty events. Now that we are in the recovery phase from that major incident that we faced within the hospital, and continue with the decontamination areas, because it's what we need to do. Now, some of the areas in the hospital, as you know, they have improved on them. We are all aware that some of the regions, emergency departments, part of ONG, there's been new alarm systems. And all people, when they are there, you need to understand what those alarms are. And we'll continue to train. If there are areas that you haven't been told how to do that, please make us aware. But all healthcare workers have to be able to respond when there's an incident in the hospital, when there's a fire in the hospital, when there's an instruction for evacuation, that you familiarize yourself with the expectations of what needs to be done. And most of you and some of you might have already gone and attended some of these training sessions around how to put out fire, who to activate, who to inform in the middle of the fire. And the long and short, you phone the switchboard and we are able to follow it up, and they will take it through to us. Most of you by now, you should be aware of where the evacuation and the assembly points are. You need to know that if I'm in admin, this is next to block 6, just across it. If I'm in the emergency department, I come across and I move out and I empty it. That includes the ops and gynae emergencies. If I am in the first block and the second block, that we will usually come out using the hospital street. If I'm in block 3 and block 4, I'll go down and avoid the lifts in case of fires and use the stairs and evacuation and make my way out of the parking at the back of the hospital. If I'm in block 5, I also have the opportunity to use the other side of the hospitals and the tunnels to evacuate from the hospital. Know where your assembly points are. Always be aware of them so that we can be able to evacuate in an orderly manner, in a calm manner, even when we're having events within the hospital itself. So more of the training, and people need to know things that needs to be done when you've picked up. And here is an example about the evacuation. Who moves first? How do we activate it? And what systems to follow around the windows. For example, in fire, we close the windows. In bombs, we open all the windows, if that is what we are afraid of. But those are some of the things that we will continue to work with you so that you are well informed should an incident happen in your part of the hospital. There are certain things that we do at the background that you might not be aware, and those are done with collaboration with other fire marshals as well as other members. So, to see the fire extinguishers, to check what levels they are in, to make sure that they have not expired, to also make sure that they are at the correct levels. But that is something that is done at the background, and it's work that needs to continue to be done moving forward. So for me, an overall introduction and overall information on behalf of the committee is that please familiarize yourself with the roles that you need to play during mass casualty events. Avail yourself based on emergency codes. Code red is everybody, wherever you are, please come and assist. And you go to assembly hall. From assembly hall, you'll be told where you are needed most. You must be willing to assist whenever we are in trouble. So this even implies that even when the hospital information has not got through to you, but you can pick up on the radios and the community informations and the TVs that the hospital is on fire, you need to start coming and anticipate that we will need you until otherwise stated. In every area, there are job cuts. No, when I'm in theater, when they say code red, what do I need to do? How do I make theater available? When I'm in ICU, what am I expected to do? How do I make beds available? How do I mobilize more staff? And it goes to every part of the hospital in terms of our job cut, including the management and those that are not in the clinical pathway. But when we are having events, please come and participate actively and obey the rules and the orders that are given. You might be a well-trained specialist, but you might not necessarily understand everything around the safety, the philosophy, and the management during mass casualty events. And I want to reiterate that all of us have a role to play in emergency situations. I hope this gives you an understanding so that when we delve deeper into what your role is, we've got an overall plan around the hospital expectations. Thank you very much for listening, and have a lovely and a brilliant day.